I wish to welcome you to this third virtual lecture on the anatomy and physiology of the urinary system, where in this particular lecture, we are going to look at the mechanisms that underlie formation of urine. We call this the renal processes. There are three basic renal processes that we're going to look at. Just to put this lecture into perspective, we've been doing a series of lectures on the urinary system. I chose to divide this into 5 parts for the sake of ease of delivery. The first one, we talked about some introductory concepts of the urinary system. Then we also majored on the gross anatomical structure of the kidney, as well as overall functions of the kidney. In the second part, we narrowed down to the histological structure of the kidney, and we also talked in great detail about the microscopic organization and functions of the nephron. In this third lecture, largely focusing on physiology of urine formation, this is the one we are calling mechanisms of urine formation. We are going to focus on 3 basic renal processes. After this, there'll still be 2 other lectures. One will be on the structure organization of the urinary passages, as well as the physiology of micturition, which is urination. And lastly, we'll have a lecture on development and congenital malformations of the organs of the urinary system. So welcome to this particular lecture on the 3 basic renal processes. This is what we're going to focus on. We'll start with just a brief review of the macroscopic parts of a section kidney. Then we'll also do a brief review of the structure of the nephron and how blood flows through the nephron, because that anatomy is important for us to understand the physiology of urine formation. After that, we're going to focus on the 3 major renal processes, and then in great detail, we'll focus on each of them. So the first one is what we call glomerular filtration. We'll look at it and we'll see how it is regulated. And then the second one is tubular reabsorption. And the third one is tubular secretion. We'll also look at how that goes. We will finish with mechanisms of urine concentration. We are going to see why the kidney needs to concentrate urine and what mechanisms are available for that particular purpose. So starting with the macroscopic parts of a section kidney, in the very first lecture on anatomy of the urinary system, we said that a section kidney has 3 basic parts. The outermost part is what we call the renal capsule, which is a connective tissue that covers the kidney. This connective tissue also enters through the renal hilum, and it's continuous also with the adventitia of blood vessels, as well as the outer covering of the calyceal system. The second component of a section kidney is this region, which we call the renal parenchyma. The renal parenchyma consists of renal pyramids, these regions here, or let's say the renal medulla, where the renal medulla has the pyramids. And we have this region here, which we call the renal cortex. We have extensions of the cortical tissue into the medulla. The extensions of the cortical tissue into the medulla is what we call the renal columns. Similarly, we also have extensions of medullary tissue into the cortex, best seen histologically than gross, but we call them medullary rays. Remember that the renal parenchyma refer to the region of the kidney that contains the nephron. This is the region where urine formation takes place. The third component of the kidney is the pelvocalyceal system. The pelvocalyceal system consists of the urine passageways within the kidney. The pelvocalyceal system is centered within this larger region, which we call the renal sinus. The renal sinus is the extension of the renal hilum into the kidney. It contains the pelvocalyceal system as well as adipose tissue and blood vessels and nerves. When we look at the components of the pelvocalyceal system, we talk about the minor calyces, which receive urine from the papilla of the pyramid. Minor calyces take urine to major calyces, and major calyces take urine to the renal pelvis, which will eventually then go to the ureter. In terms of the location of the nephron on the renal parenchyma, it is important to note that the renal corpuscle, which is the region for filtration of urine, is the one located within the renal cortex. However, the renal cortex also contains the proximal and the distal convoluted tubules, but that will depend on the type of the nephron as well. The renal medulla contains the loop of Henle as well as the collecting duct. That one also will depend on the type of the nephron. Okay, so that was macroscopic parts of a section kidney. Now we can review the parts of the nephron and also how urine flows through around the nephron. We can describe the nephron as having two major components, the renal corpuscle and the renal tubules. The renal corpuscle consists of the glomerulus and its Bowman's capsule. This is where urine formation takes place, or rather urine filtration takes place. We call that glomerular filtration. Then from there, the filtrate goes through what we call the renal tubules, largely consisting of three major segments: the proximal convoluted tubule, which has characteristics of high absorption. And then we have the loop of Henle with both a descending and an ascending limb. And we have the distal convoluted tubule. The distal convoluted tubule has important functions in terms of having what we call the macular denser cells within it that are able to detect the concentration of sodium in urine. So those are the three major segments of the renal tubules, but beyond the tubules, we have the collecting tubules and the collecting ducts, which receive urine from the nephrons. The collecting tubules and the collecting ducts are also important in various functions of the nephron, and we'll still talk about their functions in this particular lecture. In terms of different varieties of nephrons, remember we have what we call cortical nephrons and juxtamedullary nephrons. Some important differences between the two. The cortical nephrons are short and their loops are largely within the renal cortex. Such cortical nephrons have a very insignificant length of the thin ascending limb. It's hardly there. But the juxtamedullary nephrons, on the other hand, have very long loops of Henle. These loops of Henle are largely within the renal medulla. And importantly, they also have a thin ascending limb of the loop of Henle, which is hardly there in the cortical nephron. These juxtamedullary nephrons are the ones which are very vital in the urine concentration mechanisms of the kidney, as we're going to see. There's something called the juxtaglomerular apparatus that we also talked about in previous sessions. The juxtaglomerular apparatus refer to this region where the terminal portion of the thick ascending limb, as well as the initial portion of the proximal convoluted tubule, make contact with the renal corpuscle. We call that region the juxtaglomerular apparatus. There are some specific cellular components in this region that are important to note. We have macular denser cells, which are specialized epithelial cells of the renal tubule, which detect the concentration of sodium in the renal tubules. We also have the juxtaglomerular cells, which are modified smooth muscle cells within the tunica media of the afferent arteriole predominantly. These are the cells that secrete renin. The juxtaglomerular apparatus are important in the tubuloglomerular feedback mechanisms of the kidney that help to regulate blood flow, as we're going to see in this particular lecture. Now, this is how blood flow through the kidney. We have that big artery in the body, which we call the aorta. Aorta gives you branches to the kidney, which we call renal arteries. So each kidney has its own renal artery most of the time. You may have some variations of access renal artery, but they're still called renal arteries. When a renal artery reaches near the hilum of the kidney or within the hilum, it divides into some segmental branches. Most of the time, we have about 5 segmental branches. These segmental branches are the ones that enter the kidney, and they give you other branches which run between the lobes of the kidney. Remember, a renal lobe refers to the renal pyramid and the surrounding cortical tissue. So there are many lobes. So we talk of interlobar arteries as the arteries that are between the pyramids generally. The interlobar arteries give you arteries that run in the plane between the pyramids and the cortex, the base of the pyramid and the cortex. We call them arcuate arteries. They're given at almost 90 degrees. They arc. These arcuate arteries are considered to be end arteries, to mean that there are no anastomosis between them. Arcuate arteries then give you what we call the cortico-radiate arteries. These are the tiny arteries that run from the base of the pyramid towards the capsule of the kidney. And so they radiate through the renal cortex, the cortico-radiate arteries. There are very many. These cortico-radiate arteries are the ones that give rise to the afferent arterioles. The afferent arterioles are the blood vessels that go to the glomerular tuft of capillaries. And so from the glomerular tuft of capillaries, we have a vessel called the efferent arteriole that comes out. In this image, this is the afferent arteriole that goes to the glomerulus, then efferent arteriole that comes out. The efferent arteriole then gives you capillaries. Some of these capillaries will go around the loop of Renal, hence termed the vasa recta. And some of them just go around the proximal and the distal convoluted tubules, simply called the peritubular capillaries. Whether through the vasa recta of peritubular capillaries, these blood vessels then coalesce to form venules and then veins, eventually following the same pattern that the arteries followed, all the way to the renal vein, which then drain into the inferior vena cava. So that's the blood flow through the kidney. In particular, I want you to understand that we have an afferent arteriole, glomerulus, efferent arteriole, then we have peritubular capillaries and vasa recta. Now we can focus on the main subject matter of this lecture. The 3 basic renal processes. These are the mechanisms that underlie formation of urine. Now, the rate at which substances are excreted from the body through the urine actually represent the sum total of these 3 processes. The first one is what we call glomerular filtration. We'll talk more about it, but in simple terms, the seepage of large amounts of fluid from the glomerular tuft of capillaries into the Bowman space. Then we have tubular reabsorption, which is the uptake of substances from the filtrate in the renal tubules back into the bloodstream in the peritubular capillaries. And lastly, we have tubular secretion, which is the release or further release of substances from the bloodstream into the renal tubules, not necessarily through the renal corpuscle. So step one is what you see there as glomerular filtration. Step two is uptake from the renal tubules to the bloodstream. And step three is substance from the bloodstream entering the renal tubule, tubular secretion. So as I've already said that the rate at which a substance will be excreted from the body through urine will be a sum total of these three mechanisms. Let's put more attention then to the first renal process, which is glomerular filtration. We are also going to see how glomerular filtration is regulated. So by definition, glomerular filtration is the pressure-dependent seepage of plasma from the glomerular tuft of capillaries into the Bowman space. When blood comes through the afferent arteriole, go through the glomerular tuft of capillaries, some plasma will seep through from the tuft of capillaries into the Bowman space. That process is pressure dependent. Most of the substances will actually move freely from the tuft of capillaries into the Bowman space. And because of that, the concentration gradient, the concentration of the filtrate is almost similar to the concentration of plasma. We can say that the filtrate at the Bowman space and plasma are almost iso-osmolar because of that. There are a number of substances which are not allowed, however, to pass through, even though we say most substances pass through. So in particular, blood cells, whether red blood cells, white blood cells, usually don't go through the glomerular filtration barrier. Also, proteins, most proteins don't go through here because proteins are bulky and are negatively charged as well. And so they're repelled or not allowed because of their size to go through this filtration barrier. Otherwise, the other substances which are found in blood go through. Now, the process of glomerular filtration occurs through a number of structures. One, we have fenestra. These are holes within or through the capillary endothelial cells. Remember that the afferent arteriole is a blood vessel and it opens into a tuft of capillaries. The capillaries within the glomerular tuft are lined by endothelial cells. These endothelial cells have holes through them, which in the previous session we call fenestra. And capillaries with the holes through their walls are termed fenestrated capillaries. So the glomerular capillaries are fenestrated capillaries. It is these holes that allow movement of substances from the bloodstream through these holes to the extravascular spaces. So filtration occurs through these holes. In this image, we see the endothelial cell there. Those black dots are the fenestra through which substances will pass from the lumen of the blood vessel. The other thing that allows filtration to take place are what we call the filtration slits. These are gaps between the podocyte processes. Now, the podocytes are these specialized cells which line the visceral layer of the Bowman's capsule, if you remember from the previous lecture. the visceral layer of the Bowman's capsule has podocytes. The finger-like projections between them interdigitate with others, and the gaps between these finger-like projections are called the filtration slits. So substances pass through those slits as well. Now, the capillaries being epithelial cells, it means that they have a basement membrane. The podocytes also being epithelial cells, they have a basement membrane. The basement membrane of the two cells are usually fused. We call that one the fused basal lamina or the glomerular basement membrane. That one is also a barrier to filtration. Now look at this highly magnified image to understand that concept well. Consider this side to be the lumen of the capillary, and consider this one to be a capillary endothelium. So there's some gaps between the capillary endothelium, holes which we call fenestra or fenestrations. And this at the end, consider this to be the lumen of the Bowman's capsule, so the Bowman space. And these are the finger-like projections of the podocytes. So between them are gaps which we call filtration slits. Substances will move from this side through the fenestra, then encounter the fused basal lamina, then go between the finger-like projections of podocytes. So that means through the filtration slits to enter the Bowman's space. So when you look at these structures we've talked about, the glomerular capillary endothelium, which are fenestrated, the podocytes of the visceral layer of the Bowman's capsule, which have finger-like projections, and the intervening basement membrane. Those three structures constitute the glomerular filtration membrane. And this is the barrier to glomerular filtration. This barrier is subject to a lot of occlusion because of the substances which are being transported through, and sometimes also because of some immune complexes being deposited around here. To prevent clogging, we have some cells which we call mesangial cells. They are phagocytic cells of the kidney. They continuously clean the glomerular filtration barrier to prevent clogging. That does not mean 100% success, but at least there is something that helps frequent clogging. So the mesangial cells are phagocytic cells. They are found around and within the glomerulus. Well, you usually have two types of mesangial cells, the intraglomerular mesangial cells, which are the ones we're talking about right now, and extraglomerular mesangial cells, which we talked about in the previous session, also called the Lassie cells. So these intraglomerular mesangial cells clean the glomerular basement membrane. The mesangial cells are usually contractile. They are able to contract. And because of their contractile ability, they're also able to regulate glomerular filtration because they can influence the amount of blood flow as well that go through this particular region. So they also regulate glomerular filtration. Right. Now, usually, there's a lot of blood that flows through the kidney, generally. We can talk of approximately 1.2 liters of blood passing through the kidney each minute. Now, remember, blood has various components, but largely into two. We have the plasma and the formed elements of blood, which you can call the cells. If you are to focus on the plasma, which is the fluid component, if we have about 1.2 liters of blood flowing through the kidney, out of that, you'll have about 660 ml being the fluid component, which is plasma. Of this fluid component, which is passing through the kidney, a fifth of that plasma is usually forced through the glomerular filtration barrier. So a fifth of 660 is filtered, or about a fifth is filtered into the Bowman space. So we're just saying that it's not everything that is filtered. As a matter of fact, a large amount still go without being filtered. So if 1/5 goes, then maybe 4/5 is actually going through the capillaries, then go to the efferent arterioles. It's not filtered. But 1/5 of the plasma is filtered. That 1/5 of the plasma will correspond with about 120 to 125 ml per minute of plasma being filtered. And this is what we call the glomerular filtration rate. It is defined as the volume of filtrate formed each minute by the combined activity of all the glomeruli in the kidneys. Remember, there are many glomeruli in the kidney, but their number reduces as we grow older. Normally, the GFR will be about 16 to 20% of the renal plasma flow. That glomerular filtration rate is about 16 to 20% of the renal plasma flow. I'm just talking about that ratio that we talked about. We can call this one the filtration fraction. So this 1/5 is the filtration fraction. We can take filtration fraction as the glomerular filtration rate, which means the amount that flows in 1 minute, over the amount of plasma that actually goes through the kidney. So the filtration fraction ranges about 16 to 20% of the renal plasma flow. Now, with about 125 ml of plasma per minute being filtered as the glomerular filtration rate, you'll notice that this amount is so high, really, because we can say that in one day, if you are to filter that amount of fluid, the volume of the fluid filtered to the kidney in one day will be about 4 times the total body water. If you are to look at the total body water as about 60% of the total body weight. So if you are 70 kgs, then your total body water is about 42 liters. If you are to do this arithmetics in one day, you'll realize that you are able to filter 4 times your total body water in a single day. Let's make that a bit scary. If you have to focus on the fluid, on the extracellular fluid volume, then you'll realize that GFR in one day filters about 15 times of the extracellular fluid volume. But if you are to narrow just to the plasma volume, the water within blood vessels, then the GFR filters 60 times the plasma volume. So we're just saying in these mathematical concepts that the GFR is very high. Although the amount of fluid filter is very high, because if you have to look at that in different ways, if 125 ml is filtered in 1 minute, that means you filter about 7.5 liters in 1 hour and about 180 liters in 1 day. And that's what I was saying, that is about 4 times the total body water, because that is, if you compare 42 with 180, it's almost 4 times. Although we filter that amount of water or that amount of plasma per day, only less than 1% typically leaves the body as what you call urine. We usually just produce about 1.5 liters of urine per day. Now that's amazing because we filter so much, but we don't lose it as urine. So we ask ourselves, why is that so? See, out of this one that we filter, only 1% come out, which means that 99% actually doesn't leave the body. It goes back. It is reabsorbed, as you're going to see in the next process. So we're asking ourselves, is this exercise in futility? Why should the kidney produce so much volume of water through filtration only to take back almost everything? Why is that so? 2 reasons. One, this enables rapid removal of substances from the circulation. The faster the rate is, the higher the likelihood of eliminating various substances from the body. But there's also another reason. Because of this faster rate, it is easy to swiftly control the volume and composition of the extracellular fluid within short duration of time. If it was slow, you'll take a longer duration to alter the volume and composition of the extracellular fluid. Right. So what are the determinants of glomerular filtration rate? What determines the rate at which substances are filtered through the glomerulus? If you look at the volume of filtered substances, it will be a combined effort of all the glomeruli within the kidney, as long as they're functioning. So it's a combined effort of multiple of all the glomeruli in the kidney. The glomerular filtration rate is proportional to the following. 1, the pressure gradient across the filtration barrier. And we are going to elaborate on that one shortly, because there are different types of pressures. The oncotic pressures and the hydrostatic pressures. The oncotic pressures are the ones created by proteins, either within the blood vessels or within the Bowman's space. And hydrostatic pressure, the pressure created by the fluid, again, either within the blood vessel or within the Bowman space. So we want that net pressure gradient. Of course, the higher the pressure gradient, the higher the rate of filtration. The other thing that is a determinant is the total surface area that is available for filtration. This is influenced by the number of functioning glomeruli, the total number of functioning glomeruli within the kidneys. The third factor is the permeability of the glomerular filtration membrane. So you may have so much of the glomeruli which are there, but their thickness is abnormal. Maybe the filtration barrier is abnormally thickened, so the permeability is impaired. So the ease at which substances pass through the glomerular filtration barrier is an important thing. That's what we call permeability. These are the 3 major things, but for each substance, there are also other things that also matter for each substance. Importantly, the charge in that substance. The ones which are negatively charged will tend to be repelled at this barrier. as opposed to the ones which are positively charged. And also the molecular size. The larger particles will tend to not go through as opposed to the smaller particles. So these are the determinants of the GFR, but I want us to elaborate more on this concept of pressure gradient. The net filtration pressure, which is the pressure gradient, is important, and so I want us to talk about it. Now, when you look at the net filtration pressure at the glomerular capillaries, it will be almost similar to what we have in the other capillary beds in the body. So as I said, depends on two things, two types of pressures. We have hydrostatic pressure gradient across the capillary wall. So we have hydrostatic pressure within here in the blood vessel within the capillary, and hydrostatic pressure within here. So the gradient of pressure there is a determinant. The higher the gradient, the higher the rate of filtration. And then we have the colloid osmotic pressure gradient again across the capillary wall. The colloid osmotic pressure is created by the proteins. So the proteins inside here vis-a-vis the proteins inside here. Now, there's something you need to understand about hydrostatic pressures and colloid osmotic pressures. The hydrostatic pressure provides a forward force that promotes filtration. However, the colloid osmotic pressure provides an attractive force, not a push, but a pull force, which means that if the colloid osmotic pressure within the capillaries are high, then you reduce the likelihood of substances going through. But if the pressure here is low, you increase the likelihood of substance going through. Similarly, if the proteins here were more, then it will pull substances, so it will promote. But if the proteins here are few or less, then that does not provide a pull force that will promote filtration. So understand that the colloid osmotic pressures operate as a pull force, while the hydrostatic pressures operate as a push force. The net filtration pressure will be the sum total of the forces. So if you look at the hydrostatic pressure, it's a push force. Then you take care of the others as well. Now, in this particular formula, you can see we expected to add the colloid pressure, osmotic pressure within the Bowman's capsule, but it's not being added here because it is negligible. Okay, so I've already told you that the colloid osmotic pressure of the plasma proteins are important because they provide a pull force, and so they oppose glomerular filtration rates. This colloid osmotic pressure is influenced by a number of things as well. It will be determined by the proteins, the pressure, osmotic pressure offered by the proteins within the glomerular capillaries. But there's also another factor. It is also determined by the filtration fraction. We've already defined what filtration fraction is, the proportion of renal plasma flow that is filtered. And we say it ranges between 16 to 20%, about a fifth. Now, how does this affect the colloid osmotic pressure gradient? If we filter a lot of fluid. When fluid comes like this and you filter a lot of fluid, if the filtration fraction is high, it means that what remains inside here become more concentrated with proteins. And so it will raise the colloid osmotic pressure. And if it raises the colloid osmotic pressure, it becomes an increasing opposing force for further filtration. So understand that the higher the filtration fraction, the higher the colloid osmotic pressure. Okay, how about the hydrostatic pressure gradient? So the hydrostatic pressures refer to the pressure offered with the fluids. So there's the fluid within the glomerulus and the fluid within the Bowman's space. The major determinant will be the fluid within the glomerulus, because the one that's highly variable, the one within the Bowman's space, is not that variable. So the hydrostatic pressure of fluid within the glomerulus promote glomerular filtration, which means that the higher this pressure, the higher the rate of filtration. What determines the pressure inside here? The pressure inside here is determined by the mean arterial pressure of the body. So the blood pressure of this particular person will influence this one. However, this is not all the time, because within some physiological range, the kidney is able to auto-regulate the amount of blood that flows through it. We would expect that if the blood pressure is high, then the blood flow here is high, or would expect that if the arterial blood pressure is high, then the hydrostatic pressure is also high, and things like that. If the blood pressure is low, then the hydrostatic pressure is also low. We would expect that to happen, and it is indeed true that it happens, except there's a particular physiological range where changes in the arterial blood pressure do not affect the amount of blood that flows through the kidney, and therefore does not affect the hydrostatic pressure within the capillaries of the glomerulus. We'll talk more about that when we discuss renal autoregulation of blood flow. There's something else that also influences the glomerular hydrostatic pressure. This is the degree of afferent arteriolar resistance. How much resistance is being offered by this blood vessel? So remember, if it is vasoconstricted, it will reduce blood flow into the capillaries, and that will reduce the hydrostatic pressure. If it is dilated, it will increase blood flow into the capillaries, therefore increase the hydrostatic pressure. The third determinant is the degree of efferent arteriolar resistance. How? If you vasoconstrict here, and you need to understand this, if this region is vasoconstricted, the pressure here increases. However, that can only happen within some limits. If it is severely constricted, then even the renal blood flow will be reduced significantly. Anyway, let's understand it this way simply. Vasoconstriction of the efferent arteriole raises the hydrostatic pressure, and vasodilation of the efferent arteriole lowers the hydrostatic pressure, because now fluid just pass like a highway. So there is no stasis, there is no pressure buildup. So understand that afferent arteriole and the efferent arteriole operate under different mechanisms to affect the glomerular hydrostatic pressure. I want to elaborate more on the effects of the afferent arteriole and the effects of efferent arteriolar resistance on renal blood flow as well as glomerular filtration rate. Let's begin with the effects of afferent arteriolar resistance. So this image here shows you afferent arterial, and then glomerular tuft of capillaries, then efferent arterial. And through here, we need to have filtration taking place. If the afferent arteriolar resistance is low, so somewhere here, which means that this vessel is vasodilated, let's say to near maximum. What will that mean? It will mean that there'll be a lot of blood that now can flow into the glomerulus. And so that means the renal blood flow is high, the blue tracing there. The renal blood flow will be high if you have a lower afferent arteriolar resistance. And if the renal blood flow is high, it means that the hydrostatic pressure will also be high. And that will therefore also mean, therefore, high glomerular filtration rate, now the red tracing. However, if the resistance here is increased, which means there's vasoconstriction. So as we increase the resistance of the afferent arterial, we reduce the renal blood flow. The renal blood flow reduces with increasing resistance of the afferent arterial. Because of the reduction in the renal blood flow, we are going to have subsequent reduction in the glomerular hydrostatic pressure. And because of that, therefore, we're also going to have a reduction in the rate of glomerular filtration. So this is the graph that represents the relationship between the afferent arteriolar resistance, renal blood flow, glomerular filtration rate. That the higher the resistance of the afferent arterial, the lower the renal blood flow, hence the lower the filtration rate. However, the lower the resistance of the afferent arterial, the higher the renal blood flow, the higher the hydrostatic pressure, the higher the glomerular filtration rates. How about the relationship between the efferent arteriolar resistance and those two other parameters? Now, this will be key also to understand. So we're talking about here, if you have vasodilation vis-a-vis vasoconstriction of the efferent arterial, how does that affect renal blood flow and glomerular filtration rate? Let's start with the relationship between efferent arterial and the hydrostatic pressure. So let's look at it this way. If you cause, okay, maybe we start with the relationship between efferent arterial and renal blood flow. That will be easier. So if we cause vasoconstriction of the efferent arterial, it means that we increase the resistance of efferent arterial. We will reduce renal blood flow. The amount of blood that flows through will be reduced. And so if you increase the efferent arterial resistance, the renal blood flow decreases. And if you lower the efferent arterial resistance, the renal blood flow increases. That one is straightforward. Now let's look at the relation between efferent arterial resistance and the hydrostatic pressure. If I increase the resistance at this point, blood will come in, but you'll not find it easy to pass through. So there'll be a pressure buildup here. Therefore, increasing resistance of the efferent arteriole raises the glomerular hydrostatic pressure. And lowering the resistance of the efferent arteriole lowers the glomerular hydrostatic pressure. Now that has implications on the rate of the glomerular filtration. How? We have understood that anything that raises the glomerular hydrostatic pressure raises the glomerular filtration rate. And so we'd expect that graph to behave like that. That if you have very low efferent arterial resistance, then the hydrostatic pressure is also low. Therefore, glomerular filtration rate will also be low. But as we increase the resistance of the efferent arterial, what happens? We increase the hydrostatic pressure within the glomerulus, and that therefore promotes glomerular filtration. And so glomerular filtration rate increases with constriction of the efferent arteriole. However, this graph does not go upwards forever. And the explanation is this. If you continue to increase the resistance of the efferent arteriole, you'll start to significantly affect renal blood flow. And so as you significantly affect renal blood flow, therefore, the glomerular filtration rate is also going to be, by default, reduced. So the relationship between glomerular filtration rate and efferent arterial resistance is not a continuous upwards graph like that. Yes, it will go up, then start to decline because of the significant reduction in renal blood flow. So understand that graph as well. Understand that's a bit different from the other one. Here, further increase in the resistance of the efferent arteriole significantly affect renal blood flow. So the graph between GFR and afferent arterial resistance is on your left. Compare that with the graph between GFR and efferent arterial resistance on your right, and understand why there's that term there, because of the effect on renal blood flow. So physiologically, how is the renal blood flow controlled? And how does that therefore also in turn affect the glomerular filtration rate? The main determinant for glomerular filtration rate that is most variable and subject to physiological control is actually the glomerular hydrostatic pressure. Because you know the proteins don't change that rapidly, but these are the ones change rapidly. There are both extrinsic mechanisms as well as intrinsic mechanisms that control the hydrostatic pressure. So the extrinsic mechanisms rely on either hormones or neuronal mechanisms. The intrinsic mechanisms are the mechanisms. One, we have the sympathetic nervous system. Sympathetic nervous system affects blood vessels. Usually, if you have the normal stimulation, it may not affect renal blood flow and GFR. But if you have a very strong stimulation from the sympathetic nervous system, a strong stimulation causes vasoconstriction of the blood vessels in the kidney, therefore increasing their resistance. And this reduces renal blood flow and renal and glomerular filtration rate. Remember, a strong stimulation by the sympathetic system. The usual ones are not affecting the kidney because of its autoregulatory mechanisms. Angiotensin 2 is another hormone to consider as affecting renal blood flow. Within its physiological limits, it causes preferential constriction of the efferent arteriole as opposed to the afferent arteriole. Now understand, within its physiological levels, it will only affect the efferent arteriole and not the afferent arteriole. The afferent arteriole is relatively spared within physiological range. It can only be affected within, or rather by high levels of angiotensin 2 beyond physiological levels. So within physiological limits, therefore, we can say that angiotensin 2 will cause vasoconstriction of the efferent arteriole. And yes, that lowers the renal blood flow, but it increases the GFR from the mechanisms we just explained in the previous slides. There are other hormones as well, and autocoids. Autocoids are these chemicals that are produced locally within the kidney. So things like epinephrine, which is adrenaline, norepinephrine, which is noradrenaline, endothelins, those ones usually constrict renal blood vessels. And because of that, they cause lowering of the renal blood flow. Therefore, GFR is also lowered. Things like prostaglandin E2, prostaglandin I2, which is prostacyclin, bradykinin, nitric oxide, these ones cause vasodilation of the vasculature within the kidney. And because of that, there is increased blood flow and increased glomerular filtration rates. There are also autoregulatory mechanisms that control renal blood flow. And I want to talk about these autoregulatory mechanisms in great detail. So what is renal autoregulation of blood flow? It's the maintenance of a relatively constant renal blood flow despite fluctuations in the mean arterial pressure. We are aware that our mean arterial pressure fluctuates easily. You stand up, you sit down, you lie down. The mean blood pressure actually changes. There are a lot of fluctuations. Somebody scares you, the blood pressure changes. You run from one point to another, even in 5 seconds, blood pressure changes. So there are a lot of fluctuations on the mean arterial pressure. The kidney is able to maintain a relatively constant blood flow despite the fluctuations on the mean arterial pressure. This constancy of renal blood flow is important because it enables the kidney to maintain a constant GFR. You don't want every time you run for 5 seconds, 10 seconds, your GFR changes. We want the kidney to be able to maintain a relatively constant GFR despite the alterations or fluctuations in the blood pressure. It is because of this relatively constant GFR that the kidney is able to precisely control electrolytes within the body. The things that need to be excreted will be excreted, and the ones that need to be retained will be retained. So the autoregulatory window is very unique. Look at this graph. Despite changes in blood pressure, as we can see on the lower graph there, the amount of renal blood flow remains constant within some limits, despite the increase in renal blood pressure. The renal blood flow remains constant within some limit. And because the renal blood flow remains constant within some limits, the glomerular filtration rate also remains constant within some limits. Maybe we understand it from this other graph as well. So the one below shows you the mean arterial pressure. within the range, as you can see in this particular graph, within the range of 80 to 180. This is the autoregulatory range. Some books will give you 70 to 180, 70 to 160, 70 to 200, 70 to 210. So anyway, it's a range. It's a variable range. As a concept, anything that falls within this particular limit of the mean arterial pressure may not affect much of the renal blood flow. Renal blood flow is maintained constant within the mean arterial pressure of 80 to 180. And because of that, the GFR will also remain constant at 125 ml per minute. However, if you have a decrease or a decline in the mean arterial pressure, let's say below 60, then you will significantly lower the renal blood flow and GFR as well. And if you have the mean arterial pressure going beyond, let's say 220, then you'll definitely also increase the renal blood flow and GFR, but that also causes glomerular damage. The reduction in the mean arterial pressure will lower renal blood flow and GFR, partly because of the reduction in the hydrostatic pressure. So you impair the pressure gradients. And that is why if you have significant hypotension, then the kidneys shut down. You get what we call acute renal failure. But if the blood pressures are so high, they affect or they destroy the glomerular basement membrane. They destroy the glomerular filtration barrier. So you lose a lot of things again through urine. The GFR will increase, but at the expense of destroying the kidney. The autoregulation of renal blood flow is achieved through two key mechanisms. There's what we call myogenic mechanism. This is what we call tubuloglomerular feedback mechanism. Let's start with the myogenic autoregulation. The myogenic autoregulation basically reflects the property of smooth muscles in general. For vascular smooth muscles, when you stretch them, they contract. And if you don't stretch them, they relax. Now, why is that so? The explanation for that is this, that if you stretch smooth muscle, then you'll allow more calcium to enter into the cell, and that will increase the contractility. Therefore, if you stretch vascular smooth muscle, as what would happen in scenarios of increased blood pressure, if there is increased blood pressure, and so the smooth muscles, vascular smooth muscles are stretched, they will respond by increased contractility. And if they respond by increased contractility, it means therefore that they increase resistance to blood flow. Therefore, maintaining the blood flow constant. If there's a fall in the blood pressure, the smooth muscles will therefore be relaxed, and so more blood flow into the kidney. But if the blood pressure is very high, which means it's threatening to increase the renal blood flow, then the blood vessels in the kidney offer resistance. And so that helps to maintain the blood flow at a constant rate. That is the myogenic autoregulation mechanism. How about the tubuloglomerular feedback mechanism? The tubuloglomerular feedback mechanism are mechanisms that link changes in the concentration of sodium chloride within the macular denser cells with the control of afferent and efferent arteriolar resistance. So this image shows you, and this graph shows you, if you have renal arterial pressure, the renal arterial pressure influences the glomerular capillary pressure, the hydrostatic pressure. And that also influences the glomerular filtration rates. The glomerular filtration rates influences the reabsorption of solutes from the proximal tubule. And it also affects the reabsorption of solutes at the rest of the tubules. For example, if the renal arterial pressure is high, the hydrostatic pressure is going to be high. And that means that the GFR is also going to be high. If you have high GFR, a lot of solutes are delivered in the proximal tubule. And that means that more solutes will be reabsorbed in the tubule. Again, yet a lot of solutes will be available in the distal tubule, and so more solutes will still be reabsorbed there. This increase in GFR that increases reabsorption is an important concept, which we call glomerular tubular balance. An increase in GFR increases reabsorption, and a reduction in GFR reduces reabsorption, just based on the fact that if you deliver much into the PCT, then much will be reabsorbed. And if you deliver less into the PCT, then less will be reabsorbed. Now, that is glomerular tubular balance. That is different from tubuloglomerular feedback. In tubuloglomerular feedback, we are looking at the amount of solutes that are delivered in the distal tubule. And the concentration of solids that are delivered in the distal tubule are the ones that affect the renal blood flow. Now, you may ask yourself, how is that possible? This is possible based on the mechanisms mediated by the juxtaglomerular complex, the juxtaglomerular apparatus. There are two major mechanisms involved. There are those mechanisms that influence the afferent arteriole. So we call them afferent arteriolar feedback mechanisms. This involves the release of vasoactive substances that alter the resistance of the afferent arteriole. For example, if the GFR is increased because of perhaps increase in blood pressure, it means that the amount of sodium being delivered in the renal tubules is also high. If that is so, it means that the macular denser cells will detect a lot of sodium again within the DCT. This will cause release of adenosine. Now, adenosine diffuses and acts on the afferent arteriole. It causes constriction of the afferent arteriole. If you have constriction of the afferent arteriole, you reduce glomerular blood flow because increase in resistance of the afferent arteriole reduces renal blood flow. And so you see, because of that mechanism, there'll be a reduction in GFR. Remember, it started with increase in GFR, but now we have a reduction in GFR. Similarly, let's say that the arterial pressure is low. That means that the hydrostatic pressure is low, and so GFR has gone down. If GFR goes down, it means that the amount of sodium that will be delivered in the DCT will be also low. Now, that is because of multiple mechanisms, either because of the less amount that was delivered, but also because there'll be more time for the filtrate to spend in the PCT. And so there'll be more absorption, reabsorption at the PCT. So the amount of sodium being delivered to the macular dense will be low. That will cause the release of substances that will cause vasodilation of the afferent arteriole. So if you have vasodilation of the afferent arteriole, then you increase renal blood flow, hence you increase the hydrostatic pressure within the glomerulus. So those are afferent arteriolar feedback mechanisms. We have release of vasoactive substances that can either cause vasodilation or vasoconstriction of the afferent arteriole, depending on how much sodium is being delivered to the DCT. We also have mechanisms that operate to regulate the resistance of the efferent arteriole. So we call this one efferent arteriolar feedback mechanisms. These ones largely operate by secretion of renin. Hence, even angiotensin will be secreted eventually. So the efferent arterial mechanisms are angiotensin II based mechanisms. We had already explained the effect of angiotensin II on the efferent arteriole. I told you that if you have physiological levels of angiotensin II causes vasoconstriction of the efferent arteriole preferentially. And so vasoconstriction of the efferent arteriole usually causes increase in efferent arterial resistance, and that will increase the hydrostatic pressure. So that if you have a fall in the mean arterial pressure, and so there's a fall in hydrostatic pressure, there'll be a fall in GFR. There'll be a reduction on the amount of sodium that is delivered to the DCT. That will promote renin secretion. In the previous classes, we saw that there are multiple mechanisms that promote renin secretion. So one is just the low sodium being delivered, but could also be sympathetic stimulation as well. Right, so if the levels of sodium delivered to the DCT are low, this will promote renin secretion. Eventually, we'll have angiotensin II being secreted more, and this acts on the efferent arteriole to cause vasoconstriction. And so because of that, there'll be increase in the hydrostatic pressure, and that will therefore help to basically increase the GFR. Remember that if you cause vasoconstriction of the efferent arteriole, you do not necessarily increase renal blood flow. You actually reduce renal blood flow, but hydrostatic pressure will be increased within physiological limits. So in summary, there are multiple mechanisms that affect renal blood flow. There are those mechanisms which are intrinsic. There are those mechanisms which are extrinsic. The extrinsic mechanisms involve the neuronal mechanisms that generally affect the general blood pressure of the body. The intrinsic mechanisms are mechanisms within the kidney that adjust the renal blood flow despite the changes in the systemic blood pressure. So things like, let's say we have a reduction in the systemic blood pressure. There are some neuronal mechanisms that will operate to help that be adjusted. For example, if you have reduction in systemic blood pressure, it means that the baroreceptors are going to be not activated. And that means that because of that, sympathetic nervous system is going to be stimulated. Usually, if you activate the sympathetic nervous system, you'll cause vasoconstriction. You'll also promote renin secretion, and that will therefore eventually increase the systemic blood pressure. Those are neuronal mechanisms that also operate indirectly through the hormonal system to increase blood pressure. On the renin-angiotensin aldosterone system itself, It's also a big system that controls blood pressure related to renin, angiotensin, and aldosterone system. We explained this system largely in the first lecture, so I don't want to repeat much about it. But there are still extrinsic mechanisms, although the intrinsic mechanism of autoregulation partly uses as well, as you can see that link there. Now, regarding the intrinsic mechanisms, we've talked about the myogenic mechanism, a reduction in blood pressure will cause a less stretch of the vascular smooth muscle. And because of that, less calcium entering into the cells. Because of that, there is reduced contractility, and so there'll be vasodilation of the vessels, and that increases GFR. For the tubuloglomerular feedback mechanism, understand that if you have a reduction in the GFR, it means you're going to have a reduction in filtrate flow as well as a reduction in the amount of sodium that is along the renal tubules, including macula densa. And because of that, you're going to cause renin secretion that will operate to eventually constrict the efferent arteriole within, among other mechanisms, that will increase the GFR. But also, there'll be chemical mediators being released to the afferent arteriole that cause vasodilation that eventually also help to increase GFR. So those are mechanisms that help to regulate renal blood flow and glomerular filtration rate despite changes in the systemic blood pressure. Great, so that is glomerular filtration and mechanisms of its regulation. So having finished that, we can now look at the other two processes of urine formation, that is tubular reabsorption and tubular secretion. We will start with the tubular reabsorption. So by definition, tubular reabsorption is the selective reuptake of substances from the glomerular filtrate, whatever has been filtered, which is found within the renal tubules, from the glomerular filtrate back into the bloodstream. And this will be the capillaries around the tubules, either PCT, DCT, or the loop. Now, understand that some substances, such as glucose and amino acids, are almost completely reabsorbed from the tubules. And so you don't expect to have much of them in the urine. The excretion rate for this substance in normal scenario is almost zero, if not zero. So this process shows you the process of tubular reabsorption. If a substance is completely reabsorbed, then you'll have zero amount of it in urine. However, there are a number of substances, and this applies largely to ions, which are usually reabsorbed, but at different rates. And so you still find them in the urine, but again, you still have a lot of them being reabsorbed. So things like sodium, chloride, bicarbonate are highly reabsorbed. Their reabsorption rates are different depending on the needs of the body. So such substances, yes, even though they are reabsorbed, they're still passed in urine. But that means what? That the amount that is passed in urine is less than what was filtered. Then we have some substances, and metabolic waste may fall in this category, that are poorly reabsorbed by the renal tubules. And so such substances are excreted in large amounts. For example, if you have a substance that is actually filtered through the glomerulus, but it's not reabsorbed, that means that the amount that is filtered is almost the same as the one that is in urine. Such a substance is very ideal, therefore, for estimating the rate of glomerular filtration, because what is filtered here is similar to basically, or rather what comes out here through urine is similar to what was filtered. Right. I want us to talk about mechanisms of tubular transport. What mechanism that the kidney use to transport substances, especially the mechanisms of tubular reabsorption. There are some small proteins which may be found within the filtrate, and some small peptide hormones that are also found within the filtrate. These ones usually go back through the process of endocytosis. So remember, they're not very small molecules, even though I'm calling them small proteins. They're not as small as compared to sodium, chloride, and the like. So these ones will be transported through the process of endocytosis. Remember endocytosis, where the cell engulfs the material in question into it, and so it's reabsorbed. Apart from this, the other substances move through different mechanisms. There is what we call paracellular transport. Paracellular transport simply refers to transport of substances between the cells. For example, here, if this is the lumen and this is the wall of the renal tubule, let's say the PCT, this is the peritubular capillary. So one substance to move from here that way. We have indicated that proteins and some peptide hormones will be taken in through endocytosis. So they'll be engulfed from this end that way. Then we've also indicated that's what we call paracellular transport. So this is transport between the cells, like what we see here. Substances that move between one cell and another will be transported paracellular. So they come from this side, the apical membrane, to this side, the basolateral membrane. The basolateral membrane is the one next to the peritubular capillary. The apical membrane is the one next to the lumen. The ones that are transported through paracellular transport will only be through diffusion. So it's just based on their concentration gradients. Even this image shows you. So from the lumen on this side, we have paracellular transport, substances move between cells, eventually to get into the bloodstream. Apart from paracellular transport, we also have transcellular transport. The transcellular path refers to transport of substances through the cells. And substances which are transported through the cells can either be transported along their gradients. It could be a chemical gradient or electrical gradient, but along their gradient, and that is diffusion basically. So that's a passive transport. But you can also have substances being transported against their concentration gradient. That's an active transport. So this will apply a lot to solids. Solids can go through the cell actively against their concentration gradient or passively along their concentration gradient. Of course, there are still other solids that don't have to go through the transcellular path, so they use the paracellular path. Water also uses both the paracellular path as well as the transcellular path through osmosis. Remember, osmosis is simply diffusion of water molecules. Now, for substances to move through various routes, either through the cell or between cells, this other substance, the one I'm talking about, they can either use ion channels, they can use exchanges, they can use co-transporters, and they can use pumps. Pumps are the ones that transport substances against their concentration gradients, so they use metabolic energy. Ion channels are basically free channels that allow movement of particular substance. Exchangers are like these ones, or this one, which take a substance in exchange with another one out. And in most cases, these ones usually tend to balance the charges. For example, here we see sodium going in, but in exchange with hydrogen coming out. Which means what here? That if you look at sodium, from the lumen, sodium is entering the cell. It is being reabsorbed. But in exchange, we have hydrogen being released. So hydrogen here is being secreted. That's tubular secretion. So that's an example of an exchanger. That is a sodium hydrogen exchanger. You can also have other exchanges. Then we have co-transports. A co-transport is transport of two or more substances along the same path, along the same direction. Like we can see here, glucose, sodium co-transport, sodium amino acid co-transport. So co-transport will be movement of substances along the same direction. These are the different mechanisms of tubular transport that I want you to grasp. I want to use an example of the proximal convoluted tubule to illustrate to you, therefore, how various substances may be transported along the renal tubules from the filtrate back to the bloodstream. So let's start with the one written number 1 here. On the basolateral side of the cells of the PCT. Remember, this is basolateral side next to the peritubular capillary, and this is the apical zone next to the lumen. So on this basolateral side, we can see that we have sodium-potassium pump. What is the role of sodium-potassium pump? Sodium-potassium pump usually pump 3 sodium out of the cell for every 2 potassium into the cell. So that means what? We have a lot of sodium-potassium pumps on the basolateral side that take sodium out of the cell. Because of this active transportation of sodium out of the cell on the basolateral side, we create a negative gradient of sodium inside the cell. And because of this negative gradient of sodium inside the cell, the concentration of sodium in the filtrate will now be more than the concentration of sodium within the cell. And because of that one, on the apical zone, we'll have a downhill movement of sodium. That is basically diffusion of sodium from the lumen into the cells. Now, usually, the movement of sodium into the cell is tagged with some other substances like glucose, amino acids, and even other ions and vitamins. And so it's a co-transportation kind of a mechanism. Now, number 4 shows you movement of water from the lumen into the cell and from the cell into the interstitial space and eventually into the bloodstream. Usually movement of water will be through the paracellular transport, simple diffusion, but also through the cell using what we call aquaporins. These are channels of water that allow water movement. They're called aquaporins. Things like lipid-soluble substances can diffuse freely through the cell membrane. Remember, the cell membrane is a phospholipid bilayer structure. And so lipid-soluble substances just move freely from the filtrate back to the bloodstream. And this is influenced largely by the movement of water. That if water is reabsorbed through its aquaporins from the lumen into the bloodstream, then it creates a high concentration of solids here. And because of that high concentration, the solids then become reabsorbed easily. After water has moved, the other solids will move because of the concentration. Great. So that just explains some mechanisms of transport of substances in the proximal convoluted tubule. What are the physical forces that govern tubular transportation and especially tubular reabsorption? The net reabsorptive force represents the sum of hydrostatic and colloid osmotic forces around this region. We come back to the hydrostatic and colloid osmotic forces again. What factors will favor reabsorption? The factors that favor reabsorption would be if the hydrostatic pressure in the renal interstitium is more than the pressure within the blood vessels. So anyway, hydrostatic pressure within the renal interstitium here, remember that the lumen is on this side, then these are the cells. Between the cells and the blood vessel, there is interstitial tissue. So we are looking at substance moving from the interstitial tissue to the bloodstream. What factors favor that movement? One, the hydrostatic pressure within the renal interstitium will promote forward movement, but also the colloid pressure within the capillaries will pull substances. The mechanism that oppose this will be now the peritubular hydrostatic pressures, that hydrostatic pressure within the capillaries, peritubular capillaries, as well as the osmotic pressure of the proteins within the interstitium. Remember, they pull. So these are the forces that govern reabsorption. But generally, the net reabsorptive force is usually about 10 millimeters of mercury if you sum up those 4 combined. We mentioned that the normal GFR is about 125 ml per minute. The normal rate of reabsorption is about 124 ml per minute. So we need a good balance between glomerular filtration rate and tubular reabsorption. How is this balance maintained? We have the glomerulotubular balance, which we had already indicated earlier, that if you have an increase in GFR, you'll have an increase in the reabsorption of solids. You'll also have an increase in the reabsorption of water, and this largely affects happen in the PCT. And because of that, in general, the percent of solids reabsorbed is usually held constant. Then there's another mechanism, pressure natriuresis and diuresis. This is based on the fact that when we increase the renal arterial pressure, the urine output also increases. If you increase the renal arterial pressure, we increase renal urine output. And if we reduce the renal arterial pressure, we reduce the urine output. If you remember that there's a particular period of autoregulation, so anything outside the autoregulatory window, this law will apply. Lastly, we have some hormones that also control specific substances. They control the reabsorption of specific substances. These hormones include the aldosterone hormone, antidiuretic hormone, atrial natriuretic peptide, parathyroid hormone, and angiotensin II. Let's see what these hormones do. We start with aldosterone. Remember, aldosterone is produced by the adrenal cortex, specifically the zona glomerulosa of the adrenal cortex. Usually it's under the influence of angiotensin II anyway. So aldosterone hormone is a mineralocorticoid. It acts primarily on the collecting tubules and collecting ducts of the kidney. The effect of aldosterone is to promote the reabsorption of sodium and chloride. And because of that, through osmotic drive, even water is also reabsorbed. Usually, the reabsorption of sodium is usually in exchange with potassium. And so we can say, therefore, that aldosterone also promotes the secretion of potassium. It is for this reason that the drugs, diuretics, that usually inhibit the action of aldosterone are therefore said to be potassium-sparing diuretics, because it means you're not going to lose potassium now if you use such diuretics. Antidiuretic hormone is the other hormone produced by the neurohypophysis, that is the anterior pituitary gland, but under various mechanisms. The antidiuretic hormone acts on the distal convoluted tubule of the kidney, the collecting tubules and the collecting ducts of the kidney. The effect is to promote the reabsorption of water. Now, upon reabsorption of water, especially in the outer zones of the renal parenchyma, so that means that the upper parts of the collecting ducts, the concentration of urea will increase within the renal medullary tubules. And because of that, if you have increased concentration of urea within the medullary ducts, you're going to have increased reabsorption of urea as well. So these one come as a result of this. The third hormone, atrial natriuretic peptide, produced by the atrial cardiac musculature. This one is produced during stretch or when the cardiac musculature is stretched, especially the atrial musculature is stretched in situations of fluid overload. Atrial natriuretic peptide acts on the DCT, collecting tubules, collecting ducts, as well as the juxtaglomerular apparatus of the kidney. It acts to inhibit sodium reabsorption, and that means even chloride reabsorption. So because of this, atrial natriuretic peptide will actually promote the loss of sodium in urine. And that's why it's called natriuretic. It also inhibits or lowers renin secretion by the juxtaglomerular apparatus. It is one of the hormones that actually lowers the blood pressure, because if you do this, you lower renin secretion, you reduce sodium reabsorption. It means therefore that there will be a lot of water being retained within the renal tubules. So you lower blood volume, you lower blood pressure. The parathyroid hormone produced by the parathyroid glands, principal cells of the parathyroid glands are the ones who do this. We call them principal chief cells. Parathyroid hormone acts on the proximal convoluted tubule, the thick ascending limb of the loop of Henle, as well as the distal convoluted tubule of the kidney. It lowers phosphate reabsorption, but increases calcium reabsorption. So parathyroid hormone increases the concentration of calcium within the bloodstream. Angiotensin II is the other hormone. Angiotensin II acts on the proximal convoluted tubule of the kidney, the thick ascending limb of the loop of Hendel, the distal convoluted tubule, as well as the collecting tubules of the kidney. Angiotensin II promotes sodium and chloride reabsorption, and so water will also follow. But importantly, angiotensin II also promotes the secretion of hydrogen. Perhaps it's important to understand the mechanisms mediated by angiotensin II further. Let's look at them this way. Angiotensin II is perhaps the body's most powerful sodium retaining hormone. It increases sodium as well as water reabsorption from the renal tubules through three major mechanisms. One, because of its effect on the zona glomerulosa of the adrenal cortex by stimulating aldosterone secretion. So because it stimulates aldosterone secretion, aldosterone will in turn promote sodium and water reabsorption at the kidney. The other mechanism is on its effect on the efferent arteriole. We said that within its physiological limits, it causes efferent arteriolar constriction. This increases the resistance of the efferent arteriole. Now, if you have constriction of the efferent arteriole, this lowers the peritubular capillary hydrostatic pressure. Now remember, it is now peritubular, not the hydrostatic pressure within the glomerulus, which is actually elevated, but the hydrostatic pressure within the peritubular capillaries, that one will be lowered. If you lower the peritubular hydrostatic pressure, as we saw in the previous slides, then you increase reabsorption of substances. Again, because of efferent arteriolar constriction, we agreed that there will be elevation of the glomerular hydrostatic pressure. If you elevate the glomerular hydrostatic pressure, we increase the GFR. If you increase the GFR, or if you increase the filtration fraction, then what happens? The concentration of proteins within remain a lot. And so the colloid osmotic pressure of the peritubular capillaries go up. And remember, this is a pull force. So this will, through that mechanism, there'll also be increased tubular reabsorption of substances. Third mechanism is basically direct stimulation of sodium reabsorption within the renal tubules via different mechanisms. For example, on the apical membrane, angiotensin II acts to stimulate the sodium hydrogen exchanger. So it promotes absorption of sodium in exchange with hydrogen. So that is why we said that hydrogen secretion is also an effect of angiotensin II. So this is on the apical cell membrane. How about on the basolateral membrane? On the basolateral membrane, angiotensin II promote the activity of the sodium-potassium pump, which releases 3 sodium out for every 2 potassium into the cell. And remember, this gradient was important so that we can promote more sodium entering the cell from the lumen. The third mechanism is that angiotensin II stimulates the sodium bicarbonate co-transportation at the basolateral membrane as well. So these are the mechanisms mediated by angiotensin II to promote tubular reabsorption. That is the second major mechanism of urine formation. Now I want us to talk about the third mechanism, and this is tubular secretion. Tubular secretion is a selective release of substances from the peritubular capillaries. This step level 3. From the peritubular capillaries into the renal tubules. Examples of things which undergo tubular secretion be hydrogen, potassium, drugs, toxins, organic acids, organic bases, bile salts, oxalate and urate, and a lot of substances. Now, tubular secretion occurs along different parts of the renal tubules, although again, we know that most of them may actually just occur again still at the PCT. Some of these substances which are secreted are end products of metabolism and need to be eliminated rapidly from the body. And so perhaps the glomerular filtration only is not adequate to rapidly eliminate them. That's why they need another help, tubular secretion. So though we have glomerular filtration, some of these substances are still further secreted. If you have a substance that actually undergoes both glomerular filtration and tubular secretion and is not reabsorbed, such a substance can actually be eliminated very fast from the body. And the amount that is found in urine is much more than what is filtered by the glomerulus. What is the importance of tubular secretion? The importance is to dispose substances that are tightly bound to plasma proteins, which means that these substances may not have been filtered because they're tightly bound to plasma proteins. So if they're not if they're bound to plasma proteins, they may not be filtered at the glomerular filtration. So this tubular secretion offers a better mechanism of eliminating such substances. It is also important to eliminate substances that have been reabsorbed. So maybe there was tubular secretion, but they were reabsorbed. So again, it offers a mechanism of eliminating such substances as well. It's also important to get rid of excess potassium. You realize that potassium is almost reabsorbed fully when it goes through the renal tubules. It's reabsorbed fully. So if there was no tubular secretion, you'll hardly find potassium within urine. Almost all the potassium that is found in urine is actually as a result of tubular secretion based on aldosterone mechanisms. Well, tubular secretion is also important for acid-base balance. This is through the regulation of hydrogen secretion based on the needs of the body. Let's make a summary of tubular transportation, where we are going to talk about what happens in various segments of the nephron in terms of both tubular reabsorption and tubular secretion. Let's start with the proximal convoluted tubule. The proximal convoluted tubule is the main site of tubular transportation. A lot of substances are indeed reabsorbed at the proximal convoluted tubule. And in this image, we can see a number of substances which undergo tubular reabsorption: sodium chloride, bicarbonate, potassium, water, glucose, amino acids, and the like. Remember, things like amino acids and glucose are 100% reabsorbed if they are within physiological limits. So nutrients basically undergo full reabsorption at the PCT. The other substances are significantly reabsorbed. Usually between 65 to 70% of those substances are actually reabsorbed. The fluid within the PCT has similar concentration like the one in the filtrate at least, before those reabsorption mechanisms take place. So let me say this, the fluid being delivered to the PCT is isosmotic to the plasma. Now from the PCT, we go to the descending loop of Renal. The descending loop of Renal is a site for water reabsorption mainly. So water is reabsorbed at the descending loop of Renal. And then we go to the ascending loop of Renal, especially the thick segment. The thick segment of the ascending loop of Renal is impervious to water. You need to understand that it is impervious to water. So water does not pass through this region. But a number of substances are reabsorbed at this point. So we have sodium, chloride, potassium, calcium, bicarbonate, magnesium. They undergo reabsorption at this region. But we have other substances which can also be secreted, like hydrogen. Then in the distal convoluted tubule, we have the early distal and the late distal. In the early distal, we have more of reabsorption of sodium, chloride, calcium, magnesium. And in the late distal, together with the collecting ducts, there's more activity going on there because the late distal and the collecting ducts have almost similar physiology. So there'll be more of reabsorption of sodium and chloride. Remember, this is basically aldosterone regulated. We'll also have a reabsorption of water, which is vasopressin regulated. There is secretion of potassium because of aldosterone. And this one largely occur in what we call the principal cells of the collecting tubules, if you remember that histology from the previous class. The intercalated cells are largely involved in acid-base balance. So they're more for transportation of hydrogen and potassium. Sorry, hydrogen and bicarbonate. Now, the collecting ducts, we have the segments which are above, so in the cortical regions, and the segments which are down in the medullary regions of the kidney. In the medullary regions of the kidney, the transportation of substance kind of change a bit because we don't have the intercalated cells at this region. So what is it transported in this region kind of change a bit. Great, so understand therefore that different parts of the nephron will transport different substances, and this is well controlled under various mechanisms. Now I want to do the last thing. I want to look at the mechanisms of urine concentration. Before we look at mechanisms of urine concentration, let's have some background information. We know that our body continuously loses water through different routes. As we breathe in the vapor, in the GIT through stool, in skin through sweat, and through kidneys, in urine through kidneys. So there are multiple ways in which we actually lose water constantly and continuously. Well, we are able to drink a lot of water to match what we lose, and many times we can do that. However, if water is in limited supply, then it becomes very vital that the urine that the kidney produces should have as little water as possible. And so this underlies why the kidney needs to concentrate urine. That yes, it must still release the urine because it must eliminate substances anyway, but let it not lose a lot of water in the process. The renal mechanism of urine concentration is vital for survival in situations where water supply is not that much. So the kidneys form concentrated urine basically by reabsorbing water. you know that we have glomerular filtration, then a lot of water is reabsorbed. So what comes out will be little water with a lot of solids. It's the mechanism of water conservation. So urine concentration is a mechanism of water conservation. The human kidney can concentrate urine to the degree of 1200 to 1400 milliosmoles per liter. This is like almost 4 to 5 times the osmolarity of plasma. Human kidney can concentrate that one. That sounds amazing, but if you compare with some sea animals or animals that stay in the desert, it's not as amazing as those animals can do actually. Now, this maximum ability of the kidney to concentrate urine will therefore dictate the minimum amount of water that the minimum amount of urine that the body should produce per day. Now think about it this way. The amount of solutes that our bodies need to eliminate each day is about 600 milliosmoles. So if you have about 600 milliosmoles that our bodies must eliminate per day, and our kidneys can concentrate urine to the range of 1200 milliosmoles per liter, then you ask ourselves, how much volume of urine is therefore necessary to eliminate 600 milliosmoles? Now that half, 500 ml of urine, is basically what is required to eliminate 600 milliosmoles. This 500 ml of urine is the obligatory urine volume. It is the minimum volume of urine that must be excreted to get rid of the products of metabolism and ions that we usually take. 500 ml per day. This 500 ml per day can have a concentration of 1200 milliosmoles per liter and eliminate 600 milliosmoles of solids. Great. Having understood that there must be an obligatory urine volume, therefore we know that we cannot fully shut down our kidneys, because if we shut down our kidneys, then we accumulate a lot of solids within the body, and that can be harmful. But again, we understand that we must still be able to concentrate urine. So what does the kidney require to concentrate urine? Two things are required to concentrate urine. One, high levels of vasopressin. Vasopressin acts to increase the reabsorption of water in the distal tubules, in the collecting duct as well. And so high levels of vasopressin are required for urine concentration. The other mechanism that is required for urine concentration is high osmolarity of the renal medullary interstitium. Now remember that the kidney has renal cortex and renal medulla. We're talking about the renal medulla, not the renal cortex. The medulla of the kidney needs to have high osmolarity because this one will create a gradient that is necessary for water reabsorption to take place through osmosis or other mechanisms, of course, again, in the presence of high antidiuretic hormone. So these are the two things which are required for urine concentration. Now let's measure on the second one. How is the osmolarity of the renal medulla maintained at higher levels? And I'm jumping to that because we've already indicated where antidiuretic hormone is produced. Remember, it's produced by the neurohypophysis. The cells are usually the hormone itself is synthesized in the hypothalamus, but stored within the posterior pituitary neurohypophysis, then released into the circulation when required. Antidiuretic hormone acts on blood vessels, vasopressin, and that's why it's called vasopressin, but it also acts on the kidney to promote water reabsorption. Now, I want to measure on this second one, the osmolarity of renal medullary interstitium. The high osmolarity of renal medullary interstitium is created and maintained by a number of factors. One is the fact that we have active transportation of sodium and chloride in the ascending limb of the loop of Henle. We have sodium being reabsorbed at the ascending limb of the loop of Henle using active transport, which means transported against their concentration gradient. Now, because of this, there's increasing accumulation of sodium within the interstitium of the renal medulla. Remember, the type of nephrons we're talking about here are the juxtamedullary nephrons, the nephrons which are important in urine concentration. Those nephrons have their loop of Henle within the renal medulla predominantly. And so the ascending limb of the loop of Henle here is also within the renal medulla. So we are saying that solids, and especially sodium from the ascending limb of the loop of Henle, is actively transported from the renal tubules into the interstitium. And so that creates increasingly high levels of osmolarity within the renal interstitium. Now, this is also coupled with the fact that the ascending limb of the loop of Henle is impermeable to water. And so even if solids go out, we don't have water accompanying the movement of solid because of osmotic drive. And so the solid here is not diluted by water that will be expected to follow, since the region is impermeable to water. The other mechanism is the active transport of ions, especially against sodium, within the medullary segments of the collecting ducts. So the medullary segments of the collecting duct, which means the deeper segments of the collecting duct, transport sodium again actively from the renal, from the tubule into the interstitium, and so that also helps to create hyperosmolarity. Third mechanism is the diffusion of urea. Now, understand the diffusion of urea this way. We know that urea is filtered and it comes out through the glomerular filtrate there. Now it passes through the renal tubules. There'll be reabsorption at the PCT, fine. Urea still comes out, come through, or rather through the renal tubules, pass through like that. When we are here, there's still some level of urea. The concentration of urea there, however, may not be that high because of the large amount of water within this region. But within this region is where antidiuretic hormone also acts. Upon the influence of antidiuretic hormone, we are going to have a lot of reabsorption of water. If you take out a lot of water within this segment, what remains in the renal tubules become hyper concentrated. And that makes the concentration of urea as well to be high in this region. The increasing concentration of urea in this zone flips over when we have a lot of water being reabsorbed. And so the concentration of urea within the ducts, within the renal medullary ducts, becomes high compared to the concentration of urea in the interstitium. that makes urea, therefore, to diffuse outwards from the medullary ducts into the renal interstitium. Last but not least, when we compare the rate at which water is reabsorbed in the outer regions of the collecting ducts, so we can call them the cortical collecting ducts, compare that with how water is reabsorbed in the medullary collecting ducts. We notice that the cortical collecting duct reabsorb a lot of water under the influence of vasopressin, and less of that happens in the medullary collecting ducts. So there's limited reabsorption of water. You know, if you are to reabsorb a lot of water here, you're going to dilute the solids within the medullary interstitium, and you may lower the osmolarity. Great, so these are the four major mechanisms through which the hyposmolarity of medullary interstitium is created. Now, to maintain the hyposmolarity of the medullary interstitium, there are two major mechanisms that help to achieve this. They are countercurrent mechanisms. So we call them countercurrent mechanisms. These are mechanisms that help to maintain or create and maintain the hyposmolarity within the interstitium. We are going to look at them. There are two major mechanisms. We have what we call the countercurrent multiplier mechanism, and we have what we call countercurrent exchanger mechanism. Let's start with the countercurrent multiplier mechanism. We'll just follow slowly. Let's look at the first one. So we have glomerular filtration has occurred, and the filtrate has the same osmolarity as the plasma and interstitium as well, because the plasma osmolarity is about 300. So let's take this as this filtrate passing through the renal tubules. It is of similar osmolarity like the plasma and the interstitium as well. This represents the interstitium within the kidney, which is similar to the one of the plasma as well. Now, we know that we usually have active transportation of sodium in the ascending limb of the loop of Henle. So in step 2 there, we see that sodium is being reabsorbed in excess from the ascending limb of the loop of Henle to the interstitium. Let's create a gradient there of about 200. Usually, the gradient of about 200 is created because of that transportation. If we create a gradient of about 200, so that means that we'll take 100 from here and put there. So the interstitium becomes 400 milliosmol, and the ascending limb remains about 200 milliosmol. This is as a result of active transportation of sodium from the ascending limb into the renal interstitium. I mentioned that's one of the major mechanisms that help to create the hyposmolarity. Now let's follow. If because of active transportation of solids, sodium specifically, into the interstitium, we've now made the interstitium to be at 400 milliosmoles compared to this 200, a gradient of 200. So we are of 400 milliosmoles in the renal interstitium. What is the implication of that? The implication here is that now the fresh fluid coming in is of a lower osmolarity compared to the renal interstitium. So what happens? We go to step 3 there. there'll be movement of water molecules from the descending limb of the loop of Henle by osmosis to balance that. And because of that movement of water, we are going to have increased osmolarity of the fluid within the descending limb of the loop of Henle. So through osmosis, fluid water moves from the descending limb of the loop of Henle and makes, therefore, the filtrate within there to be of higher osmolarity to make into equilibrium the fluid there with the fluid here. Now, guess what? If the fluid in the descending limb of the loop of Henle has already raised its osmolarity, it is the same fluid that flows into the ascending limb. And so in step 4 there, we see that the fluid that was at 400 now has moved to the ascending limb. Meanwhile, fresh fluid is coming in at 300, fine. But this one, the one at 400, is now moving to the ascending limb of the loop of Henle. What are the implications? The fluid that has gone to the ascending limb of the loop of Henle is of now 400 milliosmoles. And the interstitium was also at 400 milliosmoles. So what happens? We see that now there's no gradient again. So in step 5, the gradient is further created. Remember, the gradient should be about 200 milliosmoles. We are just repeating step 2. The gradient is created again. So if it's at 400 and this is 400, you need to create a gradient of 200. So this will move to about 350. Sorry, this will move to about 500. And this one will go to 300. You create a gradient. Basically, at any given time, there's a gradient of about 200 being created. And so the fluid that was at 200, so the fluid that was at 300 became 400, then it flew to the other side. Once the fluid flows to the other side, there is active transportation of sodium because of the fact that there's no pressure gradient, there's no concentration gradient. There's active transportation of sodium to achieve the 200 gradient, which is of the saturation of sodium on this level. And that makes, therefore, the interstitium to be of a higher osmolarity again compared with the renal tubules in the ascending limb. Now, the same procedure repeats itself now. If the interstitium is now at 500, the fluid coming in will again pull water into it, or rather, let me say this way, fluid coming in is of a lower osmolarity than the interstitium. Through osmotic drive, fluid will move again from the descending limb to the interstitium. And then again, that fluid will flow to the ascending limb. We will see that the process is just repeating itself continuously. Eventually, what happens is this, that the tip of the loop of Henle here will have very high osmolarity. And I told you that the maximum that it achieves is 1200 milliosmoles per liter. So this is the countercurrent multiplier mechanism. And why is it called so? Because as long as fluid is passing through the nephron, the osmolarity keep on increasing, it multiplies. As long as there's fluid coming in, it multiplies. Why is it called countercurrent? Because there's movement in different directions. Okay, how about the countercurrent exchanger mechanism? The countercurrent exchanger mechanism relies on the anatomy of the vasa recta. It also relies on the speed at which blood flows through the renal medulla. When you look at the amount of blood that flows through the renal medulla, compare with the amount of blood that flows through the renal cortex receives massive blood flow. Renal medulla receives very slow, minimal blood flow. So the blood flow into the renal medulla is limited, that's the statement. It's sluggish. Also remember the structure of the vasa recta, it goes down, loop, then come back. So let's consider this to be vasa recta, going deep into the renal medulla and coming back. And we are saying that the blood flow through this vessel is very slow. So what happens? First of all, that slow movement help to create enough time for this countercurrent exchanger mechanism to apply. But the minimum blood flow, the reduced amount of blood that flows into the renal medulla also help to minimize washout from the renal medullary interstitium. Anyway, let's look at it this way from number 2. So the blood that is coming in, let's assume that blood to be of similar osmolarity like plasma, which is true. So at 300 milliosmoles, the vasa recta begins its descent along the loop of Henle. So as the vasa recta descend into the loop of Henle, we realized that there was a lot of solids that were in the medullary interstitium created by the mechanisms we've already talked about. Because of that, it means that the vessel is entering in regions which are of increasing osmolarity, but the blood is flowing slowly. So that gives time for solids to actually enter into the descending segment of the vasa recta. So most solids usually enter into the vasa recta to balance the equilibrium because the interstitium is of high osmolarity compared to the vasa recta, the blood within the vasa recta. So that means that solids enter slowly. At the same time, the water within the vasa recta that's going down comes out because of osmotic drive. So water comes out into the interstitium, but solids enter through diffusion. Now, if you can imagine that, then at this point, normal osmolarity, water comes out, so that will raise osmolarity. But again, solids enter, that will also raise the osmolarity. So that happens on the descending segment of the vasa recta. By the time, because this blood is flowing slowly, by the time it's reaching down, it will have balanced the equilibrium. The concentration of the interstitium will be almost similar to that one of the vasa recta going down. By the time the blood reaches here, it is of similar osmolarity like the medullary interstitium, which is 1200 milliosmoles per liter. Now, the ascending segment of the vasa recta will now undergo the reverse mechanism of exchange. The blood here is of very high osmolarity, and so as it ascends through towards the cortex, solids will leave it to enter the renal interstitium, but water will flow into that vessel because of osmotic drive. And so we see that, yes, whatever was lost from here now goes back, and whatever this segment received is now released. That is the exchange mechanism we are talking about. So that by the time the vasa recta, blood in the vasa recta reaches the renal cortex again, it will be almost of similar osmolarity with that of plasma, very near. So that is the countercurrent exchange. So I hope you've understood the concept of countercurrent multiplier and the countercurrent exchange. As we finish, I have a question for you now. It is possible if somebody drinks seawater that they may actually get dehydrated instead of being hydrated. Why do you think that is so? Why does drinking seawater cause dehydration? Think about it. Now, the answer lies on the fact that there is obligatory urine volume that is necessary to eliminate substances. In the usual scenario, we have about 600 milliosmoles that need to be eliminated per day from the body. And we've mentioned that our kidneys can concentrate up to 1,200 milliosmoles per liter. So if the body needs to eliminate 600 milliosmoles, and our kidneys can concentrate up to 1,200 milliosmoles, then we realize that the amount of water that we require per day to eliminate the 600 milliosmoles will be 600 divided by 1,200. We get 0.5 liters, which is 500 ml of urine per day. That is the obligatory urine volume. However, seawater has a lot of salts in addition. When you take seawater, we kind of add another 1,200 milliosmoles of sodium chloride into the body, in addition to the 600 milliosmoles of solid that must be eliminated per day. So you realize, therefore, that we have about 1,800 milliosmoles that the body must eliminate per day if you take seawater. With that in mind, therefore, you will require a lot of water to eliminate the high volumes of solids that we have. And so if you do the arithmetics, you will notice that for every 1 liter of seawater that we take, the body will have to eliminate 1.5 liters of urine. Well, the 1.5 comes from the fact that the 0.5 was already obligatory that we have to eliminate anyway because of the 600. So the 1 liter of urine is the extra. In simple terms, if seawater has osmolarity of 1,200 milliosmoles per liter, then for every 1 liter of seawater, you will have to produce 1 liter of urine. But now remember, there's also the solid that are already in the body that requires 0.5 liters. So that's why we get 1 liter plus 0.5, we get 1.5 liters. So that's why we're saying for every 1 liter of seawater that you drink, you must eliminate 1.5 liters of urine. And so with the time, of course, you understand why this one causes dehydration. Great, thank you very much. That was really long, but we're done. We've done justice to this 3 basic renal processes, mechanisms of urine formation. The next lecture, second last, under this series of urinary system, will be structural organization of urinary passageways, as well as physiology of micturition. You can check out for it. Thank you very much.